listen to pilots of a hybrid on-site and telehealth model for general practice services in Centred Health, which is part of Kyabram District's health service in collaboration with Telecare.
And just to clarify, this is Dr. KC and I'm Dr. Raymond, just in case anyone was confused. Yeah. We'll get started. As part of, Telecare would like to acknowledge the traditional custodians of the lands on which we're meeting today, the Wurundjeri people, or the Woiwurrung people of the Kulin Nation. We extend that respect to Aboriginal and Torres Strait Islanders people present here today. As a kind of national service provider, we would also like to acknowledge the traditional custodians of the country throughout Australia and the connections to land, sea and community.
And on behalf of Kyabram District's Health Service, Kyabram District's Health Service and Centred Health operates in the lands of the Yorta Yorta people, and I'd just like to acknowledge the elders past, present and emerging, and that Yorta Yorta Nation has always been a place where people have worked to heal and to educate.
So the structure of the presentation, we'll go through a bit of the background, the model of care that's been co-developed together, as part of a public-private partnership, the results, and we'll go through some insights.
We're trying a public-private partnership right now.
Yes.
So, Kyabram District's Health Service in Stanhope. Stanhope is a township of about 800 people in the Campaspe Shire in north central Victoria. And noting that John McEwen of OPMs was a farmer there, in fact. It's about 20 kilometres from Kyabram, a township of about 7,000 people. 50 k's from Echuca of about 15,000 people. A lot of you in Victoria will be familiar with it as a tourist destination, and about 200 kilometres from here. The local health service, Stanhope Health, is governed by the Stanhope Health and Community Committee and is managed as part of Kyabram District's Health Services.
And as a bit of background about who Telecare are, we're essentially Australia's largest virtual specialist care provider, although in this instance we're providing specialist GP care. We have 300 clinicians registered across our panel, over 30 plus specialties, and delivering around 3,000 consultations a month. So we provide both public and private virtual care services, and we partner with hospitals to provide virtual inpatient and outpatient services, also across remote reporting. And unique to Telecare, we also develop the actual technology that we use to develop to deliver some of our care, which is a very unique aspect with our own in-house technology team. So in terms of quality accreditations, we've undergone ISO 9001, 27001, undergoing NSQ DMH for those who are in the mental health sector, and we were we were the only private provider invited to the Commission for Safety and Quality in Healthcare's pilot of potential virtual care standards.
So a bit of background of why we have undertaken this collaboration in Stanhope. The problem is essentially what we just now are increasingly referring to as a thin market, to the inadequate market provision for certain populations or in certain regions. In thin markets, some people requiring care and support may miss out on services or be forced into services that don't meet their needs, including services that are located far away from home. And that's certainly the case in Stanhope. We face significant GP access challenges following the cessation of a long-standing outreach service due to GP workforce shortages. So we had a GP clinic we have been visiting for about 2.5 decades. GP retirement, all of that stopped. And we know that surrounding towns of a similar size or even some bigger towns are facing similar challenges. So, in collaboration with Telecare, we have worked on a hybrid GP model where it really was co-designed in consultation with the local community, local businesses, families, the local Stanhope Health and Community Committee. And with the support of the Human Health Services Partnership and actual funding and project support, now it's a Human Local Health Services Network, of course. We developed an innovative model of care where traditional in-person consultations are supplemented with telehealth services to ensure continuity of care that can overcome the geographical barriers and workforce shortages. We essentially are able to, rather than rely on our small and shrinking group of local GPs, tap into a workforce coming from Melbourne.
Thanks, Casey, for setting the scene. So next, I'll run through a little bit about some of the mechanics of the model of care. So essentially, it is a public-private partnership with the clinic ownership and clinical governance via telecare, but in conjunction with Kyabram District Health Service, offering kind of governance oversight via the GPs and Community Health Project Control Group, also by the Stanhope Health and Community Committee, as well as the KDHS Clinical Governance Committee. And so the schedule that we developed together, and this was a true co-design process between February to August, over a period of 6 months. We had 2 days per week face-to-face out of every month, 1 week out of 4, and then telehealth for 3 weeks out of the other 4. Certainly though, we identified that we needed to initially build up trust with the community, so we had an initial 3-week period of full-time, on-the-ground, face-to-face general practice provision.
And reflecting on what Alison has presented, I think that's actually a really important move to build that initial trust. The seed funding came from, like I said, the Human Health Services Partnership and our local health service network. Involves the establishment of equipment, and that's sort of owned by the KDHS because we hold the facilities. There's a revenue guarantee which essentially the public sector buys vacant appointments as the business is getting started. So we pay for the difference between the patient fees generated and then the agreed per diem rate. As well as some ancillary costs around accommodation and mileage, and the public sector also paid for a formal evaluation by the Trope Uni, which informs a lot of this presentation. So that evaluation looks at the first 10 months of operations. The co-design process, so that started in February of 2024. We looked at financial sustainability, community acceptance, and safety. So the key steps included that initial assessment involving myself, a rural generalist GP, and a metro GP, looking at the initial sort of design and how to be made sustainable. In March, we formally invited for the project our medical advisory committee because as much as possible, we wanted the new service to come into a relatively friendly local medical community. We then had community and executive engagements the following month with the co-design process formally getting started, involving the whole of the Kyabram District Health Service executive team and the Stanhope Community Voices Committee to ensure the community acceptance components of the hybrid model. We then developed the actual model over the next couple of months, looking at the appropriate balance between in-person and telehealth visits, escalation pathways, and a fees policy. And that's, I guess, a combination of complex negotiations involving what the medical workforce coming from Melbourne would do, what are the expectations of the Stanhope community, and what the Human Health Services Partnership and the Kyabram local public hospital can support. And then in June of 2024, we had a big engagement plan ahead of the start of the actual service in August of 2024. We finalised all that with the negotiations and the actual practice set up in May and June, as well as signing of contracts. We will three-way thing, like I said, with Hume Health Services Partnership, the hospital and telecare. There was a site visit as part of a community engagement and trust piece, as well as the procuring of equipment in July, the actual delivery of the comms plan in July as well, and some staff training which involve training of the telecare staff as well as the local hospital staff that work out of the Stanhope Health site.
So exciting with the results. First I'll talk about the clinical outcomes. I was one of the GPs that went up to Stanhope and delivered some of the care. So while it is hard to really definitively track clinical outcomes, in the first 5 months we did some kind of basic audits, and although there was some underutilisation, which we'll talk about later, there were some key metrics that, particularly the rural generalist GP who was also part of this program, he kept a log of some of the, particularly this key kind of skin and chronic disease management that he conducted within just the first 5 months. So there were 22 skin checks with 10 requiring cryotherapy, which is just freezing of the skin with liquid nitrogen to get rid of either very early skin cancers or pre-skin cancers. There was one SCC, which is a squamous cell carcinoma, which was picked up that required subsequent grafting because it was kind of in a vulnerable area. There was one nodular basal cell carcinoma, and more importantly, one invasive melanoma, which also underwent a definitive excision with the rural generalist, which potentially we might have saved a life there, although we don't know, of course. Lots of immunisations, which the local population wouldn't necessarily have had access to. The majority of these immunisations were provided by a remote consultation by the GP and then an on-site immunisation by an on-site nurse immuniser. So kind of that hybrid model coming really into play. 15 chronic disease management plans with some reviews and health assessments. And overall, about 408 occasions of service in the first 5-month pilot period, with 156 different individuals accessing services, anywhere from 1 to 13 times, so a very wide spectrum of need. And most importantly, from a clinical safety perspective, no critical incidents.
No complaints either.
And no complaints, that's right.
Which is a great segue into the patient feedback. So as you can see, overwhelming positive feedback from the local community.
Sorry.
And a range of ways that the patients got connected into the service. The local hospital actually was able to claim credit for 40% of patients' attendees. And yeah, thought to be extremely useful in terms of
94% very useful and 6% useful.
Yep. Definitely something that patients who have attended would then recommend on to their families and friends. So
yeah, I guess we'll talk about it together. I think it's really important to always share learnings and share failures, because I think this way may be one of, I wouldn't say it's a failure, but it is something to be aware of in any hybrid model. So the blue line is the on-site visits, which tracked really nicely, but the telehealth kind of adoption rate, you can see, was a little bit flat, certainly in the first period. It is getting better now that it's outside of the pilot period, and I think one of the key learnings we'll talk about later is never use the word pilot, because people won't.
I think we've actually got some feedback from the local community. Am I going to transition all of my medical care to you, and then you're going to be finished at the end of the pilot? So that's a learning for us. The reason why utilisation towards the end of the period is more than 100% is because we were not super ambitious. I think we defined 100% as 3 patient consults per hour. We actually, with the telehealth component, increased utilisation for another round of marketing. Plus, to be honest, we decreased the number of telehealth hours in a session.
And in terms of the patient demographics, I guess some of the missing demographics were those families, I suppose, that actually a lot of them said in the feedback that they'd rather travel to Kyabram and get everything done at the same time as a family, rather than kind of again, not being sure whether this service was going to be still there.
The other groups that were a bit underrepresented compared to the census data is the very elderly, so over 80 years old, and men, although that's not uncommon in rural clinics. So very great engagement, basically for middle-aged women.
So some of the key strengths that came out of this from the La Trobe Uni evaluation, there was definitely improved access, improving timely access to medical care for residents, very high satisfaction for those patients who did use the service. There was a growth in the face-to-face appointments, indicating at least an increasing trust of the service. The practice nurse support was really key, having a practice nurse that could facilitate some of the telehealth appointments on site, do some of the basic obs. That was really, really helpful for some particularly complex patients. And an in-town GP service has actually attracted other ancillary services that are of benefit to the residents, including a pathology collection service.
And more picked up pharmacy and all sorts of things. We've got a 2-minute warning, so we'll be quick. We're focusing on challenges and opportunities. So the underutilisation is discussed in the telehealth services and what we're starting to do about that. The demographic gap was alluded to. So the financial barriers at this stage, it is a mixed billing clinic, and part of the rationale for getting telecare to own and manage it is hospital will be stuck with bulk billing, and it's not even less financially sustainable. And the worries about that, this is just going to be a pilot that we've got from the patient feedback.
Getting the deaths there from Chris. So in terms of opportunities, there are opportunities to scale, particularly in other thin markets. And to be honest, to be a financially viable service, we do need to scale to multiple remote locations that can share potentially one GP that travels around and does that maybe a whole week of in-person visits, mixed in with some telehealth visits. And then as you scale, you can potentially do fortnightly face-to-face visits, which certainly in a rural location we know residents will highly value.
And I think maybe just very finally, we're looking forward to the strengthening Medicare rebates uplift, which would be significant for Stanhope's and M5 area. The economies of scale we spoke about, and also thin markets I just wanted to maybe end with. So recognising that Stanhope's not it's not Robinson Crusoe. The Commonwealth Government has funded Murray PHN as one of 3 pilots around Australia to look at alternative models of integrated primary health. And Murray PHN has decided to operationalise it across Swan Hill, Rochester and Stanhope. So we really look forward to that support in terms of model of care development and evaluation and actual money.
I won't go through the conclusion, but I thought I would show the team at our kind of initial visit with the community. Thank you, everyone.
Thank you.